Management of sagittal malocclusion, Class 2 malocclusion. The Class 2 malocclusion regarded as the second most frequent and most distributed and the second prevalence cases of angle malocclusion after the crowding. The Class 2 malocclusion, according to the angle classification, regard or called the distal occlusion because the molar relationship in the Class 2 malocclusion include the distal position of the mandibular first molar in relation to the maxillary first molar, where the mesial-buccal cusp of the maxillary molar occlude mesially in relation to the buccal developmental groove of the mandibular first molar. The Class 2 malocclusion, according to the incisor classification, the incisal edge of the mandibular central incisor occlude posteriorly to the cingulum plateau of the maxillary central incisor. The Class 2 relationship between the mandibular and maxillary central incisor may be due to the Class 2 skeletal pattern, and the Class 2 skeletal pattern is due to either the prognathic position of the maxilla or the anterior position of the maxilla in relation to the mandible, or the prognathic position of the maxilla in relation to the cranial base. The Class 2 skeletal pattern also may be to retrognathic position or posterior position of the mandible in relation to the cranial base, or retrognathic position of the mandible in relation to the maxilla. The Class 2 skeletal pattern also may be due to maxillary excess in size or mandibular deficient in size. Also, a combination of the maxillary prognathism and mandibular prognathism. The Class 2 skeletal pattern may cause the position of the lower central incisor posteriorly to the upper central incisor. The Class 2 incisor relationship may be present on a Class 1 skeletal pattern, and in this case the proclination of the incisors and retroclination of the mandibular incisors may be due to the soft tissue factor or the dental factor, and the Class 1 skeletal pattern indicate there is no etiological factor of the skeletal part on the etiology or on the development of Class 2 malocclusion. Class 2 incisor relationship may be present on a Class 3 skeletal pattern, and in this case due to the effect of the lips and the tongue on the central incisor that cause a Class 2 incisor relationship on a Class 3 skeletal pattern, and this case are rare cases. The Class 2 malocclusion can be divided into Class 2 Division 1 and the Class 2 Division 2. In the Class 2 Division 1 or Class 2 Div 1, the incisors are proclined and the overjet, which is the horizontal overlapping between the maxillary and mandibular incisors, is increased. In the Class 2 Div 2 or Class 2 Division 2, the incisors are retroclined and the overjet is normal or minimum. And in addition, the Class 2 Div 2, the overbite is increased. The overbite represents the vertical overlap between the mandibular and maxillary incisors. In a Class 2 Div 1 malocclusion, the facial feature characterized by a convex profile. The convexity profile of Class 2 Div 1 is due to either the prognathic maxilla and retrognathic mandible, or the retrognathic mandible or the prognathic maxilla, and this gives a convex profile. In addition, the soft tissue factor, which include the lips, are affected by the skeletal pattern because the lower lip is inserted to the mandible and the upper lip inserted to the maxilla. And when the lower lip that inserted to the mandible and the mandible is in retrognathic position, it try to pull the lips backward and cause the convexity profile of the class 2 div 1 malocclusion. In a class 2 div 1 malocclusion, the lips mostly are incompetent. That means a separation between the lower and the upper lips more than 4 mm, and the lip line, which represents the lower lip line to the maxillary central incisor, is low. When the lips are incompetent due to the skeletal pattern and the low lip line, the lip will function either partly behind the upper central incisor or completely behind the upper central incisor. When the lower lip function partly behind the upper central incisor, in this case the class 2 div 1 will be worse because the effect of the skeletal pattern, in addition to the effect of the lower lip on the upper central incisor or the upper incisors, and increase the proclination of the upper incisors and increase the overjet and worsening the class 2 div 1 malocclusion. While when the lower lip function completely behind the upper incisors, in this case there is no effect of the lips on the upper incisors, and the proclination of the upper or maxillary incisors is due to the skeletal pattern only. For the dental factor, most of class 2 div 1 cases have an increased overjet because the deficient arch length that cause the incisors or maxillary incisors to procline anteriorly to compensate the deficiency in the arch length. And some cases, in addition to the increased overjet, there is a crowding in the class 2 div 1 malocclusion. The treatment of class 2 div 1 malocclusion is classified according to the age of the patient and the severity of class 2 div 1. According to the age of the patient is include the treatment of a class 2 in growing patient, that means a pre-adolescent patient who have not reached to the maximum growth spurt, and the cases who are beyond the maximum growth spurt or called the young adult or adult patient or non-growing class 2 malocclusion, and the patient adult which treated with combined orthodontic and orthognathic surgery. The treatment of class 2 div 1 malocclusion according to the severity also classified into mild and moderate and severe cases. The treatment modalities of class 2 div 1 is for growing skeletal class 2, which include the growth modification, and non-growing class 2 malocclusion, which include camouflage treatment and combination of orthodontic and orthognathic surgery. The treatment of growing skeletal class 2, who is the patient that not reach for the maximum growth spurt or the pre-adolescent patient, the treatment modalities of these cases is called the growth modification. That means we modify the growth of the maxilla or the growth of the mandible to correct the class 2 skeletal cases. The approach that used for the growth modification include the high-pole headgear and functional orthopaedic appliance. The high-pole headgear used for restrain the maxillary growth. That means the high-pole headgear used in the skeletal class 2 cases that is due to the maxillary prognathism or due to the maxillary axis, while the functional orthopaedic appliance used to place the retrognathic mandible forward. That means the skeletal class 2 in this case due to either the mandibular retrognathism or mandibular deficient, and the functional appliance used to put the retrognathic mandible in a forward position to modify the growth of the mandible forward to correct the skeletal class 2 cases in growing patient. The high-pole headgear, as mentioned before, is used to restrain the maxillary growth by applying a direct force to the maxillary molars by using of the face bow. The face bow is connected to a headgear. The headgear provides a dental effect and orthopedic effect. The dental effect means the reinforce of anchorage and distalization of maxillary molar. The orthopedic effect means restraining the growth of maxillary axis or restrain the forward growth of the maxilla, and in this case used to the treatment of class 2 cases that due to the maxillary axis or maxillary prognathism. The functional orthodontic appliance mostly increase or accelerate the growth of the mandible. That means the functional orthopedic appliance used in class 2 cases due to mandibular retrognathism or mandibular deficiency, where these appliances put the mandible forward and stimulate the growth of the condylar head to put the mandible in a forward position to correct the class 2 cases due to the class 2 skeletal pattern. The functional orthodontic appliance include the Andreessen monoblock appliance, twin block, Frankel appliance type 2, and hair-based appliance. Andreessen monoblock and twin block have the same effect on the growth of the mandible, and it is called a functional activators. These activators put the mandible forward, and the twin block have an advantage over the monoblock, and it's more adjustable and easy and comfortable for the patient. In addition, many modifications can be put to the twin block, especially the expanders or jack screws can be incorporated to the upper part of the twin block to cause expansion of the maxilla, and the expansion of the maxilla during the growth modification facilitate the forward position of the mandible and the forward posture of the mandible and easier correction of class 2 skeletal cases. The Frankel appliance type 2 effect on the soft tissue or the muscle of the cheek and the lip will put the effect of the cheek and the lips away from the maxilla or eliminate the force of the cheek and lips on the maxilla and the mandible, and in this case give a more chance for the maxilla for the expansion. The expanded maxilla in class 2 cases facilitate the forward position of the mandible and correction of class 2 skeletal class 2 div 1 skeletal cases. The Andreessen monoblock, twin block, and Frankel appliance type 2 are mostly depend on the patient compliance or patient cooperation, because it's removable appliance and inserted and removed by the patient. So when we lack for the patient compliance or patient cooperation, we need what is called a fixed functional orthodontic appliance. For example, for the fixed functional orthodontic appliance is the herpist appliance, because it fixed to the band on the teeth of the maxillary molar and mandibular premolar to posture the mandible forward to correct class 2 skeletal cases, and in this case we not need for the patient cooperation. The treatment of non-growing class 2 cases or the patient beyond the maximum growth spurt, who are the young adult and adult patient, called the camouflage treatment. The camouflage treatment means the treatment of the class 2 dental relationship to compensate the skeletal class 2 skeletal relationship. And the treatment of non-growing class 2 cases or camouflage treatment include non-extraction treatment and extraction treatment. In the non-extraction treatment, there is no need for extraction any of teeth to correct the class 2 cases, and it's indicated in mild dental and skeletal class 2 cases when there is an arch discrepancy is minimum with no adverse effect on the facial profile. That means the facial profile not affected when the mandibular incisors or mandibular teeth is proclined anteriorly and retroclined of the maxillary teeth. In addition, the overjet can be corrected by the movement of the teeth only, and not a need for the skeletal correction or only the dentoalveolar correction. In the extraction treatment, that means we need for extraction a specific teeth for correction of the large overjet and to correction the class 2 full cusp molar relationship with minimal crowding in the lower arch. In the non-extraction cases, we correct the case by molar distalization, and the molar distalization, that means distalize the maxillary first molar by using of a headgear or mini implant, or correct the maxillary first molar rotation to provide a space for the retraction of the anterior teeth to correction the mild increase in the overjet and increase in arch parameter, that means proclination of the mandibular anterior teeth to compensate or correct the mild increase in the overjet. The correction with the non-extraction treatment, either with headgear and molar distalization and molar rotation, and increase in arch parameter is used by a use of a class 2 elastics. The extraction treatment mean extraction of specific teeth, which include the extraction of only upper premolars, and in this case the molar relationship is remain and accepted as a class 2 molar relationship, while the extraction of the upper premolar is used to correct the increase in the overjet by retraction of the maxillary anterior teeth, and the mandibular anterior teeth is in a stable or correct position after making the cephalometric analysis. The extraction of the upper and lower premolars is by correction also the lower proclination and upper and incisor proclination by retraction of the upper and lower incisors posteriorly to correct the class 2 incisor relationship or the increased incisor relationship, and the class 2 molar relationship remain as a class 2 molar relationship. In cases of extraction of the upper first molar and lower second premolar, that means the extraction of the upper first molar is to correct the overjet by retraction of the maxillary anterior teeth, and the extraction of the mandibular second premolar is for correction the molar relationship from the class 2 to class 1 relationship. And the mechanic or the approach used to correction the overjet and class 2 in extraction treatment mostly either by fixed orthodontic appliance or in mild cases by a removable orthodontic appliance. The combined orthodontic and orthognathic surgery is mostly indicated in an adult patient or non-growing patient when there is a severe class 2 cases or the skeletal pattern due to the maxillary axis in combination with the mandibular retrognathism, or severe deficient mandible, and there is a crowding with the protrusive lower incisor, and the patient is a vertical grower, that means increase in the lower vertical dimension with the clockwise rotation of the mandible. In this case, we need for a combined orthodontic and orthognathic surgery. The orthognathic surgery include the maxillary impaction to correct the maxillary axis, and the segmental surgery for the mandible to put the mandible a more forward position to correct the skeletal severe cases of class 2 malocclusion. Thank you.